Wow, what a good group. Boy, they sat down quick. Okay, I'd like to get started, if we could. My name's Tom Croyle, and I'm the president of the Lehigh Valley Business Coalition on Healthcare, one of the sponsors of today's event. It's kind of a neat way this program came about. Lehigh University has been a member of the coalition for a long time. The coalition is basically around 200 employers who provide health insurance to their employees and have been interested and active in access to affordable quality health care since 1980. So we're fortunate to have Hisham on our quality committee, and he's provided a lot of great insight as to data and things like that that we're looking to do and to help our employers manage care. Donna Sable, who's also on our quality committee. Back in December, we had a kind of a roundtable discussion with some folks from Capital Blue Cross and some employers, and we're talking about all the things that, you know, we think we all agree on and how we can work to make them better, because really the American healthcare system does a lot of wonderful things, but I think we all can acknowledge that there's some room for improvement. And the program here at Lehigh, with the industrial engineering systems and the healthcare systems working together to kind of work on some of the processes and stuff, really help us address some of our concerns about providing, you know, quality and efficient care for our employees. The work that Donna's doing over at St. Luke's and Mark Wendling at Lehigh Valley Physician Group. We're so fortunate in the community here to be able to have that dialogue with providers, insurers like folks from Highmark, Capital Blue Cross, Aetna, you know, a wide range of things. And I think we're all kind of headed down the same path. And hopefully today's discussion we'll be able to share some insights and have a great informative discussion on you know, the issues confronting the healthcare system today. So, and some of the things that the folks here at Lehigh are working on to help us address. So, I guess, Tomas, if you're ready to step up and continue the discussion, I'll turn it over to you.
So my name is Tomáš Torlaki. I'm the chair of the Department of Industrial and Systems Engineering at Lehigh. So it's my privilege to welcome you to this wonderful event. A few words what I would like to say about our programs, about our offering, about our interest in healthcare systems. I don't think I have to introduce any of you Lehigh University. I think everybody knows it who is in the room. The Industrial and Systems Engineering Department is one of the oldest in the country. So we are having the Industrial Engineering program from 1923. Even our greatest competitors are acknowledging that this is the second program started in the country. The department is well over 60 years old as an independent department, and about 4.5 years ago, with my colleagues, we started to brainstorm where industrial engineering going. What is the sector of the economy where industrial and systems engineering methodologies can make a significant impact? And with the help of our advisory council, and I'm glad to see Deb Hawkins from Lehigh Valley Health Network here. At that time, she was serving on the department advisory council. We concluded that really healthcare systems is where the biggest need and the biggest potential impact to bring the industrial and systems engineering methodologies to make the biggest impact, the same kind of impact what it made first on, let's say, metal forming, manufacturing, then transportation and logistics, the airline industry, all the automation and robotic systems, streamlining all the processes. And I'm still using in my courses and in all of the other occasions, Deb as an example. She's graduated from the department. She started in Bethlehem Steel, then moved to more manufacturing assembly plants, and then ended up in the healthcare quite a number of years ago. And one of the first things several years ago, what she told me, I changed jobs, but I'm still doing exactly the same thing. So really that's as the department, with the help of our distinguished alumni advisory council members, we ended up that really healthcare systems is where industrial systems engineering methodologies are on the greatest need, and in the coming years they have probably the greatest impact. I have to add that at that time Obamacare was not in the made, or the Affordable Health Care Act as officially called. It turned out that in the last several years, I think the healthcare landscape changed. Most organizations, healthcare delivery, industry participants, hospitals, clinics, home care, pharmaceuticals, and everybody's by now acknowledging that, like it or not, the world changed. You have to do things better, you have to do things more efficiently, and more consistent quality. And those are really the methodologies what industrial systems engineering are contributing to it. So almost 4 years ago, we got to the design of the healthcare systems engineering program. Next week, exactly 3 years ago, when we hired Hisham Naba as the director of the healthcare systems engineering program. And the program, I would say, by now made great advances. Every year enrolled more than 20 students. In this coming academic year, probably exceeding the 30 new students enrollment. At this point, over 70 students are active, because most of the students cannot do it in 1 year, although technically and practically can be done by some exceptionally strong students who are doing it full time. Most students are doing it in a year and a half, who are doing, let's say, on-site, but the program can be also taken off-site, online, completely distance education way, except one thing, that the program requires that every student is taking a practice project at a healthcare-related provider. And combining the industrial engineering foundations, the healthcare knowledge, design new courses, healthcare systems, healthcare IT, quality efficiency in healthcare, and healthcare finance. And then finally, every student has to do something practically relevant with an industry mentor and with the university mentor, where Hisham is the primary contact, but also other faculty members from the department are taking part of it. Another big advance of the program, beyond all of this, that there is a 35-person industry advisory council. Extremely great people, and I see many of the members of that council also in the room. Just looking at Tom, who 4 years ago made us linked to the Lehigh Valley Chamber of Commerce, and many other ways. And we had several events we even never dreamed or even never thought it's happening. Like Hisham is sitting in a panel at the Chamber of Commerce Healthcare Summit at the same table as the president, CEO of Lehigh Valley Health Network and St. Luke's Hospital, who they didn't really sit at the same table previously before. So we had really lively discussions at that time. So the program made impact in many different ways, also gained national recognition, and it's really simply the interest in today's program. It's already a testament that all of you who come here somehow consider it to be an important element of developing a new and better healthcare systems for the future. I also would like to address that there are other elements of the healthcare systems, the healthcare delivery approach what at Lehigh we are having. So beyond the department, we also have a what we coined to be called the Integrated Healthcare Delivery Cluster. That includes the department faculty from the Department of Industrial and Systems Engineering, obviously with the Healthcare Systems Engineering program. Some of our colleagues from the Computer Science and Engineering Department, and Hank Court is also part of one of the panel. He's one of the leading person in it, and also colleagues from the Management and Economics Department from the Business School. And we are keeping it also very open and collaborative. some other colleagues from the bioengineering program also included. We visited also NIH as for a potential project just about 2 weeks ago. So the approach is, I would say, quite holistic, quite broad. Obviously, the healthcare systems engineering program is taking only the healthcare system delivery part, but healthcare IT, healthcare management, and all the other aspects, as long as we are having very willing and enthusiastic colleagues at Lehigh, so we are keeping the network and the net broad in all of this. With all of this said, I hope that all of you will enjoy today's program. I think we will have very lively, enlightening discussions. And the next item in the program is to have, let's say, some meal. And as I was told, someone will call the tables one by one. So please don't run everybody immediately there. So there's some engineering organization in the program. And after, let's say, that part of the program is over around 5 o'clock, then Hisham will come back and guide the panel discussions from there. So enjoy the evening. Thanks for coming, and looking forward for great discussions. Thank you.
All right. I'd like to again welcome you to Lehigh University, and I'm hoping that you're enjoying this evening. We have a lot of interesting discussions and panels that we're hoping to make it as much interactive as possible. And I'm hoping that every panel will have a couple of minutes at the end to have a question and answer. If you do want to ask a question, because we are recording this, I do ask that if you can please come up to the front and use one of the microphones to ask the question. Without further delay, we would like to welcome Tom again to introduce the first panel, and we'll move on with the program. Thank you.
Well, as I alluded to earlier, despite all the wonderful things the healthcare system does, it's a system that seems to be plagued by fragmentation, inefficiencies, variations in cost and quality, and an orientation towards the treatment of illness rather than population health. We're really fortunate today, and I'm really fortunate to know these folks personally, to have some experts who are wrestling with the challenges of the healthcare system in their current roles. Dr. Andy Blasichak is the Senior Medical Director, Provider Strategy and Integration at Highmark. Dr. Denise Haar is Medical Director at Capital Blue Cross, and I want to thank Denise for stepping in. Dr. Chambers called on Friday and said she wasn't going to be able to be here, so Dr. Haar is here in her place. Donna Sable, Vice President and Chief Quality Officer at St. Luke's University Health Network, and Dr. Mark Wendling, a family physician and chair of the Lehigh Valley Physicians Group. So, panelists, if you'll come up to the front. We still connected? We're good. All right. I think what I'd like to do is just kind of direct a general question out to a panelist and give them a few minutes to respond, and then comments from the others. I think I'll start with Donna. Measuring hospital quality and efficiency is really hard. Effective comparison requires transparency and a measure of public accountability, with everyone more or less using the same measures. Can we really do that in a meaningful way?
So I knew I was getting this question and was going to be the first person. So I've had a little time to think about it. But, right now we're not measuring the way we need to measure. It's very difficult to get systems to integrate. If we can measure certain siloed things, but if we really truly want to measure population health and be accountable for the well-being and the outcomes of a population, we're truly not quite there yet. The systems are there, starting to be there. We're looking at integrated electronic medical records, which is certainly going to help us. Data warehousing, I was talking with someone who graduated from this program and is working in that area right now. But we have a long way to go. And really getting down to the provider level and profiling providers on their quality is still somewhat off in the distance. But truly to be able to identify mediocre providers, poor providers, and superb providers, we're still not quite there yet.
Any of the others care to address that issue?
And I would just add from the provider perspective, I think sometimes the challenges, as Donna mentioned, is if you're looking at a particular disease state or on which you're measuring a provider, sometimes your cell size is so small. I mean, I don't want to get into the analytical or statistical piece of things, but it becomes challenging to really say you can have, one kind of bad outcome that kind of can really impact your data. So we get challenges from providers all the time that say, well, that just happened to be one thing that went bad, but it really impacted my overall score, shall we say.
Mark?
Yeah, I'll add one other comment. And the cell size comment I think is really relevant because when you look at a patient with a disease, one disease, you might be able to measure that in terms of quality reasonably well. But if you start looking at the confluence of multiple variables and how that constitutes overall population health, that's where it starts to really get difficult. The other thing I'd say is we have to remind ourselves about what patients feel is value and be able to learn, and there's work certainly underway to measure what patients feel is value. So the AHRQ is developing multiple tools, hospital-based tools, ambulatory-based tools to do that. But I think there's still work to be done to really understand what value is and, certainly to bring that into the overall equation of quality, because that's one of the ones that I think providers certainly feel is really important to them. That soft side of healthcare quality, that connection to the hospital, to the doctors they see, that's pretty important and challenging to measure.
Tom, as an insurer, we're always looking for what I call the holy grail of measures, and that is quality, cost, access to care, and patient experience. And of those, quite frankly, the quality and patient experience are by far the most difficult to measure and obtain. And one thing I struggle with is right now, we don't use the Andy Blaszczyk measures of quality. We look for national measures in quality, and the National Quality Foundation, NQF, I think they have like 800 and some different quality measures right now, and so if we ask a health system to measure 20 or 30 quality measures, and Capital Blue Cross asks them to measure 20 or 30, the chance of us having the same 20 or 30 is almost zero. And so the healthcare systems are oftentimes really overburdened in just trying to measure these measures to report to an insurer or to customers. And so I think in addition to finding clinically meaningful measures, we need to find those that are most important, if you would, so that we don't overburden the system and have people trying to obtain measures on, again, 800 different measures or so. And I know, Donna, I'm sure you struggle with this because every insurer has their own set of measures right now. And of course, they're nationally ordained, but there are just so many of them.
Well, they may have even the same measure. So let's take diabetes, for example. A blood, test, HbA1c, to measure whether your diabetes is stable or not. One insurer may have one value that they're looking for. Another insurer has another value. So it's the same measure, but an 8 might be okay for you, but a 7 is what's required of a value of 7 with someone else. Blood pressure, what is hypertension? Again, right now we're trying to manage patients' blood pressure in our practices. And we have as many insurers, we have pretty much that many values that are identified, 140 over 90, 130 over 80, And so we just decided we will go for the the value that is the best value, meaning, this is where, or what if there's a professional organization nationally who says, this is the targeted value that you want to get to for an HbA1c. The evidence is out there, it supports it. So we try to choose that and just work to that. And then all the others, if we meet that stringent criteria, we'll meet it for the others. So it's very complex. We have a matrix right now of all of the metrics for our practices, shaking your head, which honestly, it takes a long time to even get through it. So it's challenging.
And in addition to insurers and customers wanting different measures, you have to realize the government also wants probably twice as many right now.
Yeah, that kind of gets to my thing that I think about a lot is, it's sometimes easiest to measure how often providers, physicians carry out processes that are recognized as best practices. We're all in this race to do the 800 measures, but are we really measuring best outcomes? And how do we kind of focus in on that rather than just the processes themselves?
One area that, we have a lot of process measures now. We have some outcome measures, but I think it's more fundamental than that. What are the indications to do an intervention on a patient? And, are we doing too many things? Are we not doing enough? Do we do them at the right time? So that's a whole area of measurement that we haven't even begun to touch the surface of. And I think that's really a really important area that we need to start to gather metrics on and measure.
Yeah, I would amplify, appropriateness of selection of what we do is a ripe area for measurement. And also, an incredibly ripe area is it takes on average 16 years for an evidence-based proven treatment to get put into practice. So the process of putting evidence-based medicine into practice is called translation. We do translation in healthcare not very quickly and not very well. So there's a lot of talent in this room. I think we should all spend a whole lot of time on translational research, because I think that's an area I know we're looking at very seriously, doing a lot of research with translation. And I think it's an area that is ripe for a whole lot of systems engineering, frankly.
And I think just to build on what Mark just said, I think it's easy and it's almost quick to measure out or to measure processes. We can say if this then that, go from one box to the next and get your end result and say, in this situation you did this and followed the right process. Outcomes in medicine, you can't measure them necessarily in a year or 2 or 3. It's did you prevent a complication that might not have developed anyway until 10 or 15 years down the road. So we want a short-term answer to say reinforce what we're doing, and you don't have that in a year or 2. You might have that in 5 years. So you're not going to get that immediate feedback on is your process working, because you need to wait to see, it's healthcare. Did the patient stay well? Did they get that complication? Did they, did something else happen to them? So it's easy to measure the processes, so that's what we do. We have to give it time and be patient, which is not necessarily a characteristic of many physicians or clinicians. But you have to be patient and say, I think we're doing the right thing, and let's see what happens a couple of years down the road.
Denise touches on a very important point in that it's much easier to measure process and much less costly to measure process. When we launched our medical home program a couple of years ago, being the typical insurer, I think we were asking for 80 different, quote, outcome measures to be reported to us by the practices. And we found out very quickly that what we felt was a very attractive incentive to be paid if a lot of those measures were obtained didn't cover the cost of doing maybe 5 of those outcomes, let alone the time frame, as Denise said. So we are guilty of measuring process many times as an insurer. There are some outcome measures I think are pretty good, and I know a lot of the practices are now doing them, like diabetes, hemoglobin A1C control. But measuring true outcomes is timely and costly.
Well, we've been hearing a lot about population health, pay for value recently. You know, what's your perception of population health and pay for value, and why do they seem to be the recent focus, Andy?
First, let me start with the pay for value. About 15 years ago, Highmark started on pay for performance programs where we would withhold or incent physicians and health systems based on quality process, mind you, but quality measures. Our customers want to know return on investment. They want to know for the X amount of dollars that we are paying for healthcare costs, what are we getting in exchange in high quality services, again, access and patient experience. It was very difficult to quantify that pay for performance. So we and others over the last couple of years have changed gears a tad bit and have converted to pay for value. And the pay for value piece incorporates, it's a classic arithmetic equation. It's quality over cost. And you're trying to improve that quality while reducing that cost, and specifically care cost trends. So the flavor of the last couple of years is pay for value, and that value incorporates both quality, like we've been talking about, as well as cost and efficiency. So that's really the strategy of today, and for the next couple of years, you're going to see more and more pay for value by all insurers and payers, including the government. CMS and Medicare have their own pay for value as well. From the standpoint of population health, I think a lot of that is both based on the pay for value concepts, but also the Affordable Care Act has energized the concept of shared savings. And so for a population that you can care for as a health system, population attributed to you, if you can show, quote, care cost savings while improving quality, healthcare physicians, providers, healthcare systems can share in those savings, which was not allowed up until the Affordable Care Act. And so in sharing in those savings, you're identifying a population and how you're going to both improve the quality and reduce the care cost trends for that population. And so it's been an energized effort in the population health piece. There's a lot of debate, is it just cost driving the whole population health piece? I tend to disagree with that. I see true improvements in quality as well as care cost savings. Our medical home effort showed about a 30% improvement in quality while reducing care costs by 3%. And 3% on a per member per month cost of about $500 per member per month is huge to the customers. And so that's the value piece, the improved quality, reduced care cost trends.
Yeah, this one's very complex because defining value and measurement for value is really an evolving science. I think we're still figuring it out. I actually had a meeting with our team and Andy's team before this meeting tonight, ironically on the PCMH program. I think the real challenge becomes how do we depict value in an aligned way so we can actually, do what is right for patients and employers and for the communities that we take care of. Andy and Denise each have, a multitude of incentive plans that present themselves in different ways. And while we're all working in sort of the same direction, that lack of complete alignment for the incentive plans really does, I think, impede us some. So a significant opportunity, I think, is aligning the incentive plans in a very meaningful way, including Medicaid and certainly Medicare. And then I think we have to be very transparent. So that's the other movement in the population health world, which is transparency for consumers. And that's going to present itself with its own, challenges related to educating patients and bringing them into dialogue in a way and in a space that they recently have not been in. So they may now be on the hook for significant costs, and they, I think, need to really understand, what this is really about and why we're all doing this. And I haven't heard a whole lot of great conversation about that, at least in the media. So I think there's an opportunity for those of us who don't have that face to really step up the game in terms of the alignment, so that we can all research the right things and translate to the right kind of outcomes.
So Medicare, had a number of accountable care organizations that went live across the country in a demonstration project. And the data is coming out from those that they actually had very difficult time measuring anything meaningful. Those that did well are the ACOs that focused on chronic conditions, heart failure, COPD. There actually probably is some low-hanging fruit in managing patients with those conditions. No one, of course, is really addressing in a very transparent manner the whole issue of end-of-life care and the cost of end-of-life care in this country, which adds a very substantial amount of cost to care. And I understand the political reasons why. So it's more of a grassroots effort. I think that is starting to address that, but it is something we don't necessarily provide the best quality of care at the end of life in this country. And I won't say anything more about that, but it is about aligning goals and objectives and incentives. We entered into a Medicare bundled payment program. It's a 90-day program, and there are a number of bundles that we're involved in. So we are working very differently with nursing homes and post-acute providers. Readmission rates are too high. They need to come down. Coordination of care from acute care settings to post-acute, there's lots of opportunity. One of the things we struggle with, the nursing home struggles with, is what's the right information to communicate about a patient who is being discharged from the hospital that could help the nursing home care for that patient better and prevent a readmission. Again, I think another great project for those of you who are in this program. Looking outside of the walls of the hospital and to the skilled nursing facilities and those providers in home care, there is a lot of opportunity to figure out what those critical elements are that we need to communicate and communicate well that really can help improve outcomes. So there's a lot to be done. I think it's very exciting, and I think there's a lot of learnings, early learnings, that are coming out of some of these demonstration projects that will help us create and standardize things moving forward.
Dr. Hart, the Kaiser system in California and the Mayo Clinic, they're often cited as models of quality and efficient care. They rely on salaried physicians and team-based care, and these models are used at some hospitals and in some practices, but not, my understanding is not a lot. And I guess my question would be, why not? Is that something we really need to work towards?
It's a great question, and it's a hard question to answer, because if you look at some of those systems and the integration that they've been able to achieve, they're very successful because of those processes and those systems that they've put into place. But I think some of the challenges is getting there, is going through that process of organizing and assimilating your team. I would comment that I think as a characteristic, physicians are independent thinkers and traditionally have been used to kind of working on their own. I'll do it. I'll take care of it. It's my patient. And we hear more and more that medicine is becoming a team sport. And for some physicians, especially our physicians that are in school now and they're training now, they're getting it. For physicians that have been out in practice and that is not how they were trained or that was what they believed, it's really hard to take that culture and that type of an individual and all of a sudden put them on a team, because now you have a whole team of leaders, which is a big challenge. So in my former life, I was part of a multi-specialty physician group, and we ran the business. We were physicians and we ran the business. So for those individuals who wanted to be more business oriented, they kind of figured out how to be business leaders. In the latter part of my clinical years, we were purchased by a health system. That was a huge challenge. The health system had their own employed physicians, and now you had a whole group of physicians who were used to being their own bosses, who now had to form a new medical group with a whole bunch of physicians who were used to being employed and had bosses. And I will tell you that we're two plus years since that integration happened, and there continue to be challenges. And I think it's marrying cultures and it's not only the physician. I mean, that's one piece of it, the physician piece of it. It's marrying, just the leadership structure. But I think it is definitely where medicine is moving. I think more and more physicians are realizing that they can't do it all, that they need to be part of a team, but that doesn't change overnight. And so as we work on models like patient-centered medical home, implementation of electronic health records in physicians' offices, physicians who have been accustomed to scribbling notes that nobody can read in a paper chart. I mean, these are all the changes, and they may have been used to using one electronic health system, and now the new system has a different system, and these are physicians that didn't go to computers and don't know how to type. So, there are a number of challenges. I could probably go on for hours about the challenges of assimilating cultures, having lived it firsthand, but I'll open to others.
I'll take this one. As Tom mentioned, I'm the chair of our board of over 1,000 practitioners. So we've been growing at about 20% per year for the last 5-6 years. Really large physician group, but still have about half of our medical staff that's still independent. I think speaking to what Tom mentioned about care team deployment, I think intellectually we all understand what the value that a care team can bring. The problem is we don't know what that should really look like. So the patient-centered medical home experiment is really all about figuring out care teams and about reliability in the process design of care team activities. And as Denise said, we didn't go to medical school, and by the way, we went to the same medical school, ironically. We didn't go to medical school to learn any of this. So you present reliability and care team to doctors and nurse practitioners and nurses, and all of a sudden everybody gets really afraid. And the problem is there's so much low-hanging fruit in terms of reliability in healthcare process that if we could just start, really thinking creatively about how we design systems, and I know we're all doing it, but if we really get creative and start just being accepting the fact that we have a healthcare problem, right? If you can get physicians to understand that there's a real problem in healthcare, then we can do anything. Because as Denise said, we're leaders, but we really need to get to the point where we're actually investing in reliability of design of care teams and really studying that in a very serious way. So I would just amplify on that.
Just throw this one out here. All of your organizations are involved in doing sophisticated analyses of patient data. And what are, from your perspective, what are the objectives of these analyses, and what are we trying to accomplish? Donna?
Well, again, with the data that we have and the abilities that we have now, I think there's a lot that really has been done well. The first hospital quality improvement demonstration, which Medicare and a company called Premier started back in 2002, 2003, really looked at how do you get evidence-based care provided to patients, and there was a financial incentive to do so. And there were actually good results. It was a 6-year demonstration project. There were about 250 hospitals in the country. And shortly after that, and the reason Medicare did the demonstration was they were well intending to make this data public, which it is on their Hospital Compare website. So, at the beginning of that demonstration, there was a landmark study that was done, and I'm going to forget the name of the author of it, but it was in the New England Journal of Medicine. It was like 45% of patients in the country were getting evidence-based care for heart attacks, for heart failure, for pneumonia. It's really neat to see the numbers that are publicly reported today, because those numbers are well over. The top decile is at 100%, top decile performance in hospitals, 100%. The top quartile is, close behind at 99.5%. That's had a tremendous impact. We know that heart attacks are way down. Why are they way down? Because patients are getting the right medications at the right time. So there's been some really good stuff that has happened because of that. Readmission rates, heart failure readmission rates across the country, 25, 26%, 30-day readmission rates. They're publicly reported. They're starting to come down. We're now seeing them at 22%. It doesn't take a lot to prevent the readmissions in those heart failure patients, to be very honest. So, I think there's a lot of good stuff that is happening, and it doesn't take, high-level data analytics or predictive modeling to do this kind of stuff. So I think we have to work within that low-hanging fruit and improve what we can, and work to evolve to predicting which patients are going to have problems so that we can intervene. We're not quite there yet, but let's fix the stuff we can fix now. And I think in our region, our hospitals do a great job working on the things that are currently out there, and the transparent data that's out there.
I would add just a comment about just understanding data. I mean, I think from the perspective of many physicians, if you would ask a practicing physician maybe 5 years ago, because I think there's a change and definitely a shift now, but how many of your diabetics have an A1C that is controlled? Most physicians would say all of them or most of them, because that's what I do every day. I really try to provide the best care. If I understand what the guidelines are, I'm trying to get every single one of my patients to this goal. Or if you ask a surgeon, how many times have you had a complication from X procedure? Oh, I can only remember 1 or 2. But then you show them the data, show them what you've been able to compile from what you have. All of a sudden, it's kind of an eye-opener, because you don't know what you're not measuring. And so just measurement of outcomes, or of what is, and this gets back to the population health question of, just who is really your patient panel. Again, 5-10 years ago, your patient panel was who walked in the door, who scheduled an appointment with you. When we look at, again, patient-centered medical homes, some of the models of healthcare where physicians have members attributed to them, and you're responsible for those members. It's not just being responsible for the ones that choose to come and see you. It's being responsible for those that have maybe come and seen you a year back for their diabetes, but then chose not to come back because they didn't want to deal with changing their diet or exercise or measuring their blood sugar. So, data speaks volumes, and it's very powerful. And it's a powerful tool on both sides of the table. It's the clinical data that clinicians gather, and it's the claims data that insurers gather, and neither has the full picture. And, we really need to be working towards, in some way, marrying that data together that works for everybody sitting around the table, because it's a huge challenge, because that's really what's a more complete picture of the patient. And then, of course, what the patient tells you, what the clinician tells you. I mean, there's a lot of information that's not in the EMR or in claims. It's just what the practitioner may know. So,
Tom, a couple of years ago, I had the honor and opportunity to start Highmark's informatics area. And if you want to see job satisfaction, put a physician in charge of about 4 million patients' claims history and data. And it's kind of interesting. And as been said, we're not there yet, but just the volume of both process but quality measures and cost measures that we have as insurers is incredible. And sharing that has been has been very rewarding, and it's shown true outcomes. Where when we talk with physicians and health systems and just reflect back to them the data that we have, and it's claims-based, it's not complete data set. But when I meet with physicians and show physicians the total cost of care for their patients, physicians have not known that historically. They'll know their own charges, but they don't know that an MRI at site A could be $750, and the same MRI at site B could be $2,500. And so historically, they have not known that, and that's really been the newer area of use of data, and just sharing, as was mentioned by Mark, the transparency of data, not just in quality but in costs. And so it's been both rewarding, but where we're not at is providing clinically meaningful and actionable data yet. We can provide the cost numbers, some of the claims-based measures, but as physicians mature and health systems mature in their understanding of that data, they look for clinically meaningful and where are areas that they could intervene and then monitor their interventions. And we're by no means there yet. But the industry is very rich in data, but not to use a cliche, it's rather poor in information still. There's a lot of efforts in some software companies that are attempting to merge both the clinical data and the claims data. And some are doing better than others, but what they really need to do then is merge that data set and into the electronic health records, so that information is there at the point of service for the physicians and the healthcare providers. We're not there yet.
We're down to the last few minutes here, but I want to get one question in, because at the end of the day, what role should the patient play in their individual health quality, and what systems should or are required to be in place to enhance patient engagement in their individual health care? And Mark, I'd ask you to kind of lead off the response.
I knew
to
this
that
one was coming
Yeah,
my way.
it's because
Yeah, I added this question. So, first and foremost, I think you have to be transparent, right? And you have to present data that is meaningful for healthcare consumers. We're by no means there yet. We have a long ways to go. I think the question of accountability is one that is really, really one that we're going to have to grapple with. I know employers grapple with this a lot. I mean, I spend a lot of time talking with Tom and other members of the Healthcare Coalition at previous meetings about, what is the role of accountability for the consumer for their own health care? So think about this. Right now, the soft change we've made is that it affects their pocketbook. Well, really, there's a whole lot of other effects that patients have related to their ability to follow through on an evidence-based treatment or not. So right now, the patients have choice to choose to do something or not do it, and it might be the best health care that we know today. Now, I don't have the answers to this question, but I think it's a really important question that as a community of people who are working on improving healthcare really need to wrestle with. So what is the accountability for the patient? What is the accountability for the providers, for the insurers, for the for the employers? What roles do those four groups of people have, and what is their responsibility to providing reliable systems of care that are meaningful for people? So, I always use the example, it's sort of an old example now, but we still measure it. I know Andy's PCMH project measures it as avoidance of inappropriate antibiotics, right? So, people come in with a perspective that they need something, and it's Denise's and my job to say they don't. So, right, so how do we work that? Where does the accountability lie? That's just one small example. There's a whole lot of of, I think, learning and discussion, frankly, that needs to incent people in positive ways, not negative ways, but positive ways, to engage the healthcare system in reliability and evidence-based medicine. And I know the employers would like that, right, Tom?
Yes, most definitely.
So, that's a whole other area for, I think, investigation and improvement. But I feel fairly strongly that, that's a whole other, I think, area for us to work on.
Yeah, we got flashed, we got a few minutes left. I guess we want to see if we can take some questions from the audience. I didn't mean to cut the discussion off on that one, but Yes, sir. Come up to and get the mic But just in kind of as we walk up here, I think in summarizing the discussion, there's never been a more exciting time to be in healthcare or a more challenging one. And the challenge for all of us really is to do better care, better health at a lower cost.
Good afternoon. My name's Terry Thiemann. I'm a surgeon who's also in the HSE program at Lehigh. So this is very interesting, and I think this is also very germane to the studies that we students are engaged in at Lehigh University. It's interesting listening to all these panelists speak about all the information that we have at our fingertips. And yet I sense from the perspective of the patient who wants to be more engaged in their health care, getting access to the data is very challenging. For example, if I needed a hip replacement tomorrow, could I log on to Lehigh Valley Hospital website, St. Luke's website, and find out how many hip replacements are being done, what the complication rate is, what the outcomes are, and what it will cost me? The answer is no. All these places know what these are, but this is not publicly available. So for me to be a smart consumer, how do I go about choosing a really good place to shop for my health care?
You actually can log on to websites and get much of that information. I'm not sure if it's the complete picture and the picture we need, but as insurers, we do post those healthcare systems that have attained certain quality standards. And we also, and this is very recent, we're also posting healthcare costs by episode for different providers and healthcare systems. And so we're in the early stages, but a lot of that is now being published. In the past, I'm not convinced the patients were really interested in that. They would ask their family physician, who do you want me to go see? Or sometimes their health plan, who do you want me to go see from a physician standpoint? And they definitely were not interested in cost because they were not a purchaser in any way. But I think over the last couple of years with co-insurances now being maybe 20%, give or take, the patients want to be more informed purchasers as well as patients. But that information is coming out. Probably the problem is going to be there's going to be overload of it in a year or two, and what is the most important quality measure of those 800 different measures or so. But that information is out there available currently.
Yeah, the proliferation of high deductible health plans, both in the employer world and in the public exchange world, is going to drive a lot of transparency.
And I would just add that those are actually the discussions that we're having at this point. Is we know that we need to be more, quote, retail-like in terms of having that information available, and it's something that I know we're working on internally. I'm assuming most healthcare organizations, health networks, are really keyed into the cost-quality value equation and needing to have that information available. And actually, we want that to be available. So it's a good question.
Yeah, great question. Well, that's all the time we have. I want to thank you all very much. A very interesting, informative, and enlightening discussion. Thank you.
like to thank our panel for the very informative talk. And in an age where the people in New York got a Twitter 3 seconds before they felt the ripples of an earthquake in Washington, in an age where the first 3 days of the year we produced enough data to be equivalent to the data that was produced in the entire year of 2003, in a time, as Thomas Friedman likes to say, where Twitter is no longer a sound, LinkedIn is no longer a typo, and in an age where technology and the time and the data that we're producing is almost doubling every year, in an age where 10 years ago we never knew that we would need an iPhone or a smartphone, and now we can't live without it. That is the exact same example as it relates to system engineering approaches and applying a lot of the success stories in the airline industry, in the automobile industry, and manufacturing to healthcare. What we're finding is a lot of healthcare providers and industry are not realizing the importance of these tools, and we believe that within 10 years they're not going to be able to live without having a crew of at least 10 to 15 industrial system engineering folks at their facilities, and I include in that the provider, the payer, the manufacturer, the regulator. Now, the quality aspect of it obviously needs tools, and we talked about standardization, we talked a lot about the problems that exist, but in order to help the providers and the payers and the healthcare industry, we actually need the tools. And that is the topic of our next panel, and I would like to welcome our next panel to the front to discuss informatics and technology and how can that help us in the future of healthcare and the future of the quality of care. So please come up to the front. Yes.